We're going to talk about noise in the hospital, but one of the challenges is noise can be very subjective. So what I consider noise can be very different than what my 15-year-old considers noise or what my grandmother considers noise. So last year, I was actually at a hospital doing work on alarm management. They recommended a boutique hotel to stay at. So I did, along with one of my coworkers. The night we were there, as we were trying to go to sleep, I had my window open, it was nice, and I kept hearing train alarms go off, and a train's coming and the dinging starts, and I kept waiting for it to stop. It didn't. I got up and looked while they were doing work on it, so I closed my window. Still didn't help. Tried to sleep. Finally, it stopped. Great. I was just nodding off. Boom, it started again. That went on all night. I got no sleep. I met my colleague in the morning. She said the same thing. I got no sleep. It was so loud. For us, that was an unusual sound, so it kept us awake. It disrupted our sleep. I do want to go back. In terms of the hospital, for patients coming in, one study identified over 86 different sources of noise from the patient's perspective that they hear. So that's pretty significant. So why are we here now? Let's talk about this a little bit. So in terms of noise levels, a couple things to note. The 60 decibel level is typically ordinary conversation. What you see over here at the 30 is actually what the World Health Organization recommends hospitals should be at from a decibel level. I can tell you most places we go to do not ever achieve that. And if you look what it ties to, it's essentially a watch ticking, so it's very quiet. What we find instead, and you can see different noises on here, that anything beyond 60 actually starts to interfere with speech. It means it's hard for me to hear somebody else when there's noise around that goes above that. So what happens? We start talking louder so somebody can hear me. Now we're increasing the noise level across the unit as well because other people will start to talk louder. When we talk about alarms, most alarms in a critical care unit start at about 70 decibel levels and can go higher than that as well. So again, pretty significant. The other thing to keep in mind is in terms of measurements and perception, it's logarithmic. So meaning if I go from 60 to 70, the perception of the patient is that we've doubled the noise. If we go now to 80, we've quadrupled it. So again, that's something to be aware of. And if we go here, part of the reason and why this is important, more and more research is coming out showing the negative impacts of noise on patients. Now what I have on here are adults and also staff, but it's the same thing with NICUs. So again, neonates, the impact it has. So you can see in terms of increased heart rate, increased blood pressure, impacts levels of concentration, which is not good in particular for staff, clinicians, physicians. It can cause problems with wound healing. It can increase in terms of aggressive behavior. One of the big things that can also impair sleep, and we're going to talk about that a little bit more, and then it can cause some psychiatric symptoms. There's a lot of research going on even right now in terms of delirium. Is there a correlation at all? Right now, there's nothing conclusive, but again, there's starting to be more work looking at that. We know delirium can cause disruptions in sleep, but trying to figure out, does sleep disruption actually contribute to delirium, again, in particular in the ICU? The other thing is the HCAHPS score. So this gets into Medicare reimbursement. And again, the survey for patients is during your hospital stay, how often was the area around your room quiet at night? This is typically one of the lowest scoring in terms of patient responses, are the surveys that they get back. So again, it's an important area that we're not doing a very good job on. So we actually, when we do assessments, we do alarm management and we do noise as a part of that as well. And we take sound measurements. We do both spot check and continuous readings at different areas in the hospital. And these are different readings we've gotten at different hospitals. So again, staff conversation, which you can see can get to the high end of 75, but staff phones and call bells as well. And so that's what we have to start thinking about, not just monitoring alarms, but all the other things that generate noise in a hospital, even things as simple as doors closing and ice machines as well, and depending on where the patient is located, the impact that can have on them. An ice machine can be up to 75 decibels as well. And this is always fascinating because, again, we talked about the WHO saying you should be at 30. We take measurements in empty rooms and empty hallways, and the noise levels still don't come down to that, or the decibel levels, the sound levels, because of all the other sounds going on still within the hospital that seep into the room or the empty hallway. Unit doors we talked about. I was actually at a site sitting at the nursing station, and honestly, there was this huge screeching sound. I jumped. I'm like, what was that? And the staff said, oh, yeah, that's the medroom door. There's something wrong with it. It screeches all the time. And I said, doesn't that bother you? And they're like, no, we don't even hear it anymore. So that's the other problem. When we work in the hospital, we get used to the sounds. We tune them out because otherwise we wouldn't be able to get anything done. For patients coming in and families coming in, all new to them. They hear everything. They're not used to it. And again, it disrupts their thinking. It disrupts, again, their sleep patterns as well. So one of the things that generates noise that we're going to talk about now that's a heavy hitter is alarms. And again, we do a lot of work in terms of alarms. Barbara Drew did a study a couple years ago in 5 ICUs. And again, this is just monitoring alarms. And she said 5 ICUs had a total of 2.5 million monitoring alarms in a 31-day period. So if you do fuzzy math and multiply that out, that comes to 30 million alarms in a year. Now that's just monitoring alarms. Again, that's not all the other alarms, the overhead pages, the phones, the staff, everything else that's going on. So again, when we talk about the noise level in a hospital and you start looking at things like this, it becomes pretty significant. And that number, honestly, is pretty startling. The majority of alarms, and that's part of the problem, are non-actionable. And multiple studies have shown anywhere from 85 to 99% are considered non-actionable, so we don't need to do anything. So again, we really want to try and focus on reducing non-actionable alarms and unnecessary noise. Non-actionable alarms contribute to unnecessary noise. Why does it matter? Because again, numerous deaths have been reported because of alarm fatigue. So alarm fatigue happens when alarms go off all the time. And so as I said, staff tunes them out because they're going off all the time. And from their perspective, they don't mean anything most of the time that they need to do anything. So they no longer hear them, or if they do hear them, they get so tired of them that they'll make changes that aren't safe just to make the alarm stop going off. And that's then when we have patient incidents and events that can occur. So what can you do? One of the things I usually recommend is that you develop within your hospital or your health system a governance structure that really is focused on alarms and noise. Studies have shown, in particular with noise, that if you're going to be successful in actually maintaining noise reduction strategies, places are very good initially in initiating. You actually have to have a leader who is assigned this, and they actually get measured on it, because then it becomes a priority and they make sure things continue to be in place. Your staff then also knows it's important because leadership is seeing it as important and somebody's getting measured on it. Clinical alarms, a little bit different. The two are related, but again, there are lots of noises that occur in the hospital that are unrelated to alarms. So that's the first step, I would say, and then really taking a look at what's happening in your hospital and your healthcare system to find out. Some of the things in terms of noise, and again, the problem with noise as well is it disrupts sleep. And so when it disrupts sleep, again, we talked about all the negative impacts that can happen from noise. You can have impacts, again, from lack of sleep in patients. Can cause confusion in patients as well, can make them irritable. Again, some of the same things in terms of noise. In terms of healing, it can increase length of stay as well. So some of the things to consider are the built environment. First off, what can you do with what you already have? Are there ways you can redesign things? Can you move patient rooms, change a room to a waiting area that may be next to an elevator? If you're building, you really can start looking at, do we use private rooms? How do we set those rooms up again in terms of location, trying to keep them away from the areas that do noise? trying to look at, does it make more sense, rather than having a central nursing station, to actually have, again, the alcoves where nurses are as well, but then a private area where the nursing staff can go and talk. Also, when you design units, looking at having a patient hallway versus a staff and patient transport hallway. So again, it cuts down on the noise where the patient rooms are. So those are all things you can look at. When you already have a unit built, you can start looking at other things. Can we add sound dampening curtains, for instance? Also, in terms of not just on the windows, but in terms of room dividers, if you have those as well. Sound dampening ceiling tiles. You can also actually add white noise machines up in the ceilings as well. And one of the things to think about in terms of noise, it's not really silence is golden. It's really trying to identify, how do we have that layer of white noise to try and eliminate the peaks that happen in noise, which are much more stressful. And also, how do we have that white layer so when we're having conversations with patients and family where we need some privacy and people not overhearing what we're saying. So again, it's finding that balance. There are some programs that exist already. They're called Silent Hospitals Help Healing, HUSH. They have recommendations. They also have flyers and posters that you put up so staff see those, families and visitors see those as well. In terms of patients, they've done some surveys and they say some of the most disruptive things in terms of their sleep, and again, annoying being at the hospital. Noise, also lighting is another one. And so I don't really talk about lighting, but again, when we're talking about sleep, it's not necessarily noise, but it's something to think about. And then nursing interventions. Nursing interventions both disrupt sleep, but if you're going in and doing things, it generates noise. So you need to look at instituting a nighttime routine. One of those means looking at nursing interventions. How can we group things together? They did one study where they said in one critical care unit, there were 42 different nursing activities that occurred in a patient room over a 12-hour shift. So again, how do we cut that down? If we have somebody on continuous monitoring, do we really need to be going in every 2 hours to do a full assessment? We might, depending on the patient, but we might not. Again, so taking a look at that. Simple things like giving patients eye masks and earplugs. Studies have found actually help promote sleep as well, reduce the noise that's occurring. Looking at what can you do in terms of turning phone volumes down at night and your monitoring alarms as well. Again, you have the capability in a lot of the systems to say, I want the alarm to sound at this level during the night while it's a little bit louder during the day. So looking at those things as well. And then any other stimuli like overhead pages, restocking supplies. Does that actually need to happen on the night shift? Or again, can you look at doing it during the day? Even things like bed baths. When I was a critical care nurse, it was often, oh yeah, do the bed bath between 4 and 6 because it's quieter. But now we're going in again, waking the patient up. We're usually talking as well. So looking at that. Another simple one is maintain equipment. You really shouldn't have any carts that have squeaky wheels. Those should be something that are addressed on a routine basis. And leaving, it's not just maintaining equipment, it's turning it off when it's not in use. I was in one ED and there was an IV pump going off. It was in the hallway, and I kept hearing it, and I went and looked, and it was not attached to anybody. It had just been sitting there. When I asked, why is this still on? They're like, oh yeah, we took it off the patient, but nobody's gotten around to turning it off. So paying attention to those things. TVs are another big one. All the time when I walk around in hospitals and empty rooms, TVs are on. They don't get turned off. So again, simple things that can make a difference. And then implementing an actual alarm management strategy. With anything, it starts with the data. So when we look at alarms, we really want to get the alarm data and figure out where we are in terms of a baseline. Again, we do the same thing with sound measurements to figure out where we are and what we can change. And then does the data tell us about any simple fixes we can do or easy fixes related to default settings? The other thing to think about is sustainability of changes. So you really want to measure over time. Again, not just looking at alarms, but also your sound levels as well. And one of the things we talk about that you can do to try and reduce noise in terms of alarms is using remote notifications. So something going to a phone, for instance. But you need to also recognize How is that going to the phone? Is the phone ringing? Is it vibrating? We've actually done measurements on phones, and sometimes the sound from the vibration is actually louder than the lowest ringtone on there. So again, you want to look at those pieces also. This is just some work we did focused really on alarm management in MICU and also a telemetry unit to try and reduce the noise levels that were occurring at Augusta University. And this was a comment from their CMO. It's so quiet. It did make a difference, and they found that also when they were talking to the patients and the staff. So it can have an impact. Oh, there we go. These were other changes we did, and you can reduce alarms across many different ways. One is as simple as skin prep and changing electrodes every 24 hours. A couple studies have shown that just by doing that, you can reduce non-actionable alarms up to 65%. So again, a simple change to initiate. Do people still need to be monitored or not? And that's the other thing we talk about. Christiana Healthcare on their own several years ago did a study looking at telemetry utilization. There are guidelines who should be on telemetry. The American Heart Association and ACA have come out with just last year updated guidelines. And in 2012, Christiana Care said, we're going to take a look at those. We're going to see how many patients right now we have on telemetry that don't meet clinical guidelines. And we're also going to do a time motion study and say, how much time does it take a clinician to spend just doing normal day-to-day telemetry tasks? And what they found was that if they implemented the guidelines, when they did, they reduced telemetry by 70%, and they had no adverse events, and they saved about $4.8 million in terms of costs. They also reduced alarms because now you don't have as many patients on monitors making the alarms go off. They did an update in 2014, found they still kept their teleutilization rates down, still no adverse impact, and they still continued to reduce their costs on there as well. One other thing to think about besides the teleutilization, which actually the hospitalists support, is other guidelines have come out from the Society of Critical Care. They're PADIS guidelines, they're called, and it's pain, agitation, delirium, immobility, and sleep. A couple years ago, they just had PAD. They've added immobility and sleep because they say those are all really correlated together. And so in those guidelines that have come out, their recommendation is to try and reduce noise to help in terms of sleep. And those guidelines actually just came out at the end of 2018. So other guidelines to focus on. The other thing is looking at your technology and how can you use it to reduce noise and alarms. We talked about decreasing at night the levels of the alarm sounds, but it's really looking at your technology. Are there remote alarm device capabilities? So again, you can actually have the alarm sound someplace else outside of the patient room. Are there things in there that will alert you to a change in patient status, what we have called Horizon Trends? So you're alerted and hopefully catching something before an alarm goes off, so it actually becomes your safety net. So again, other tools, so talk to whatever vendor you have to find out. And again, not just with monitoring, things like IV pumps, your nurse call systems as well, how they're set up, how they're being escalated as well, and if those changes can be made or not. This is a personal story that I put in here. Actually, two of my grandchildren, premature. The first one, when my daughter-in-law went into labor early, they had her on a fetal monitor. I came into the room, my son was in there with her. He was completely freaked out. He said, it keeps going off, but every time I go get somebody, they say, don't worry about it. And the last time they told me, you can just go ahead and silence it. We showed you how to do that. And he's like, why would they tell me to do that? What if I did that and something was really wrong? And then we were at another hospital, the second one, and this was on the NICU. The alarms kept going off. And again, both my son and daughter-in-law were like, why isn't anybody doing anything? Why don't they pay attention? What came out of that for them, they didn't trust the care providers and they didn't trust the hospital they were at. They did not think they were taking good care of either my daughter-in-law and their son soon to be born, or their son after he was born. So something to keep in mind. And then the other thing, another study that just came out in 2018 by Press Ganey, where they were looking at patient experience and loyalty. So noise obviously impacts the patient experience. What they found is patient experience is 5 times more likely to influence brand loyalty, in this case, whether they go back to a hospital or not, than other marketing strategies. So again, another reason to look at it. And the last thing I'll say is what you need to think about in terms of noise in the silent hospital is to try and think of it in terms of a sacred space. And in sacred spaces, you have everything from extreme joy and happiness to extreme sadness and everything in between. One size doesn't fit all. You need to look at where the joyful places, children's hospitals where we have kids, where we need lots of noise, they're having fun. You don't want to interfere with that. Hospitals, critical care units for adults, where they're trying to rest, sleep, and heal, you need to have it a little bit quieter. So it's really looking at, again, population health, where those populations are, and what do we need our sound levels to be there.